I'm Dr. Saif Al-Sahi. Information in this presentation is at the level of postgraduate level, surgical training level, which means board surgical training, and FRCS level. The presentation is sponsored by ISIN and CME Iraq Medical Education. Our case for today is a 65-year-old gentleman who presented to the emergency department with repeated vomiting for 4 days, nausea and abdominal pain. He has a past medical history of hypertension and peptic ulcer disease. He's on antihypertensive and omeprazole, which he's not compliant to. You did the examination and his abdomen is distended. Blood results are not back yet. His CT scan showed the findings as in the picture. And what is your diagnosis? So, the diagnosis of this patient is gastric outlet obstruction. What is gastric outlet obstruction? So, gastric outlet obstruction is a group of diseases that will cause delay or obstruction to emptying of the stomach. It could be a mechanical cause, like a problem in the wall, or intraluminal, or pressure from outside causing blockage to emptying of the stomach. Also, it could be due to motility disorders where there is a reduce in the peristalsis of the stomach, and that will prevent emptying of the stomach. Patients will present with symptoms of obstruction, usually at a higher level, which is at the pylorus or duodenal level. Those patients will present with abdominal pain, which is usually due to the distension of the stomach. Also, postprandial vomiting. Patients will present with repeated vomiting after meal. They will also present with early satiety and weight loss, which could be due to benign cause and nutritional issue or secondary to a malignant disease. The site of the obstruction can be at the pylorus or might be at the duodenal level, first part of the duodenum. It also could be from the wall, like thickening or tumor, or could be from pressure outside the stomach or the duodenum, or might be also from intraluminal cause, causing blockage to emptying of the stomach. Causes of gastric outlet obstruction. Peptic ulcer disease was the major cause of gastric outlet obstruction, but recently, with the help of the PPI, it's reduced as a cause of causing gastric outlet obstruction. Nowadays, the major cause of gastric outlet obstruction is underlying cancer. In pediatric patients, the main cause of gastric outlet obstruction is hypertrophic pyloric stenosis. The main finding on examination of those patients is abdominal distension and succession splash, which is found only in 25% of the patients. It represents residual fluid and gas in the stomach. The test cannot be done within 3 to 4 hours after meal, otherwise it will be false positive. And its sensitivity for gastric outlet obstruction is not more than 50%. Assessment of patients with gastric outlet obstruction include blood tests. Due to repeated vomiting, patients will have hypokalemia, hypochloremia, metabolic alkalosis. Due to abdominal distension, there will be increase in the gastrin secretion, and that will induce increased serum gastrin level. Abdominal X-ray will show a distended stomach with air bubbles that do not cross the midline, which is specific for gastric outlet obstruction. A contrast study can be done with a water-soluble contrast, which will help to identify the underlying cause of blockage. CT scan is helpful in identifying the pyloric and gastric wall thickness. It also can show enlarged lymph nodes and mass effect that might be the underlying cause for the obstruction, as pancreatic lesions. Endoscopies are also significant in assessing patients with gastric outlet obstruction. Before doing the endoscopy, patient need to have an NG tube and suction of the gastric secretion. Otherwise, there is a high risk for aspiration. The endoscopy will help assessment of the inner layer of the stomach and duodenum. Also, it will help by taking a biopsy to exclude cancerous lesion. Management of benign gastric outlet obstruction start with conservative treatment. It should be the first step, and it will include acid suppression as proton pump inhibitors. Avoid nonsteroidal anti-inflammatory medications, and testing and treating H. pylori if positive. However, if conservative management failed, the next step will include endoscopic dilatation or surgery. Endoscopic balloon dilatation will start with an endoscopic diagnostic endoscopy. The diagnostic endoscopy is to visualize the inner layer of the stomach and duodenum and take biopsy to exclude malignant disease before starting any dilation session. The balloon dilator will be fixed over a guide wire and under fluoroscopic guidance. Sometimes, in severe strictures, multiple sessions might be required. However, if balloon dilatation fails, patients might need stent placement, which will be with or without surgery. Surgery is mainly after failure of endoscopic management, and it's the option when there is an external compression like in pancreatic lesion. If the underlying cause is a malignant lesion, usually patients will be either for curative surgery or palliative surgery. Curative surgery will aim to remove the old malignant lesion. However, patients will need a diagnostic laparoscopy or even sometimes exploratory laparotomy to assess the extent of the disease before any surgery can be done. In palliative surgery, patients will mainly have bypass surgery just for palliative measures. One of the new modalities in treatment of gastric outlet obstruction that can be used in both benign and malignant is endoscopic ultrasound guided gastrojejunostomy using luminal opposing metal stent. In this technique, we make a connection between the stomach and the jejunum, which is a small bowel loop distal to the blockage, to initiate or to create a bypass. For patients with short life expectancy, which is 6 months or less, the management will include self-expanded metal stents. These are used for patients with short life expectancy due to their complications. However, they are effective as a palliative treatment for such group. Some patients are not amenable for endoscopic nor surgical intervention. So, for those patients, there is a technique which is used. It includes percutaneous decompressive gastrostomy called PDG. So, it is a tube inserted into the stomach and extended to the jejunum. It can be used to deflate the stomach and at the same time can be used for enteral nutrition. Homework to do. What are the complications of self-expandable metal stents and why we don't prefer them for a long-term management? Thank you very much, and we'll see you soon in the next case.